Greetings to GTV viewers. I'm Dr. Sudhakar Jonnalagadda, President of American Association of Physicians of Indian Origin, established 40 years ago. AAPI represents interest of more than 80,000 doctors in USA. This is the first time AAPI doing community outreach program. We want to serve the community, and we picked November because of Lung Cancer Awareness Month. And I'm happy to say that this is the first time AAPI doing the community outreach program. It's my esteemed honor to introduce our today's moderators, Dr. Vandana Agarwal, Dr. Satish Kathula. Without further ado, as the President of National AAPI, I inaugurate first community outreach program. Thank you.
Hello viewers, my name is Dr. Satish Kathula. I'm a medical oncologist and hematologist. We are here to talk about lung cancer today. Lung cancer is the third most common cancer, and about 250,000 people are diagnosed every year in the US. And it is the leading cause of cancer death, not only in the US, but worldwide. About 1.6 million people die from lung cancer every year all over the world. And yet, it is unrecognized by many, including physicians. November is the Lung Cancer Awareness Month, and we have eminent physicians with us to educate our viewers about lung cancer, including its symptoms, diagnosis, and treatment options. We have Dr. Sanjay Dogra with us, who is an interventional pulmonologist, board certified, and he's the director of lung nodule program at William Beaumont Hospital in Detroit, Michigan. Dr. Dogra, could you explain our viewers what causes lung cancer?
Of course, it has a lot of risk factors, but the most common people should know is smoking and secondhand smoke. Besides that, other significant factors are air pollution, asbestos exposure, radon exposure, and now it has been learned that people who smoke and have been exposed to or taking beta-carotene supplements have increased risk of lung cancer. But more or less, smoking remains the most hazardous risk factor for developing lung cancer.
So, Dr. Dogra, what are some of the symptoms of lung cancer?
So, as you know, most of the time it remains asymptomatic, and those people who present with symptoms, most common symptoms is unexplained long-standing cough and sometimes associated with blood in the sputum. Beside that, unexplained weight loss or loss of appetite, sometimes chest pain, and these are the most common symptomatology. But we should always be concerned if there's a cough which is not resolving, has been staying for a few weeks, we should always check for lung cancer, particularly in those patients who have risk factors which we discussed in the previous question.
So how is lung cancer diagnosed? This is one of the common questions people have. How is it diagnosed?
Defined as screening criteria is a CT scan of the lungs, which can tell us about any opacity or any lesion in the lungs, and that initiate the whole process. After we find it on the CT scan, we can go ahead and do invasive testing that can be a CT guided biopsy if the lesion is very peripheral, or using a technique via bronchoscopy. And the latest evolution in that field is happening so fast. Now we are going towards the route of navigational bronchoscopy, and the last in the series is robotic bronchoscopy.
So Dr. Dogra, let's talk about the staging. What is staging and how important it is?
But more important is the staging, because the treatment depends on staging, and also the survival so much depends on the staging. So staging depends that if the cancer is still limited to the lungs, or it has gone to the lymph glands, which are basically small glands which are present all over the lungs, especially in the midline, what we call is a mediastinum. And then if cancer has spread outside of the lungs to distant organs. So based on that, we stage the lung cancer, but most important is to stage lymph nodes, and we need to sample those lymph nodes. Based on that, we can classify lung cancer from stage 1 up to stage 3B and then 4 if it is spread outside the lungs. But staging is very important and can be done with the newer techniques, including what we call is endobronchial ultrasound, whereby we go inside the windpipe with a camera and a very miniature ultrasound, and we look at those lymph nodes, sample them, and we can absolutely stage all the lung cancers. If some lymph nodes are not accessible to endobronchial ultrasound, then we call our thoracic surgery colleagues to do a procedure called mediastinoscopy to sample remainder lymph nodes if needed. And that is how we stage the lung cancer inside the lung cavity. Outside lung cavity, it depends where the lung cancer has spread to, say, for example, liver or bones, then we can biopsy those also and to stage the lung cancer.
While the entire nation went on a lockdown, we helped thousands of schools and colleges reconnect with their students and helped students continue studying from home. From early child development schools in Mauritius to tribal welfare schools in Andhra Pradesh and Telangana, Erudex was used as a single platform to teach and keep in touch with their students remotely. Teachers at prestigious organizations such as Kendriya Vidyalaya, Navodaya Vidyalaya Samiti, Army Public Schools, and many other private institutions are able to conduct classes and assign tests away from their campuses. To make learning from home easy for your students, we offer a seamless experience across all devices, including smartphones. Make most of our features, such as animated video lessons, mock test series for JEE, NEET, MCET, and BITSAT, and conduct live classes with Zoom or any other video conferencing apps. So don't let anything stop your students from reaching their goals. Get Erudex for your school or college today. Stay home, stay safe.
The next question I have, Dr. Dogra, is how do we prevent lung cancer? Are there any preventive measures one can take?
When we went through all the risk factors, as I mentioned, smoking is the most hazardous of them. First of all, if we somehow come out with some kind of awareness in society and community that how to avoid smoking, improve our air quality, that is one of the preventive measures. But more than that, once it has been diagnosed, and then we absolutely have to make sure that we approach these high-risk populations and diagnose this cancer very early. Because if knowing, based on the statistics, if it is diagnosed at stage 1 and is removed immediately, then the prognosis is so good, almost in 90% range at 5 years. So screening is very important. We have to identify those high-risk populations, which as per United States Task Force, at least in the United States, is between age 55 to 77, and who have smoked for more than 30 pack years and have not quit smoking for 15 years. They should have a screening CT every year. And based on that, we can hopefully catch these nodules very early in stage 1 or at the most stage 1A or 1B when the surgery can be offered.
Well, thank you, Dr. Dogra. That was an excellent answers, and appreciate you coming here to talk to us today. Surgery is a very important component of the treatment of lung cancer, and we have Dr. Rishi Reddy with us. Dr. Rishi Reddy is a thoracic surgeon and is a professor of surgery and is the chair of University of Michigan Comprehensive Robotic Surgery Program. Dr. Reddy, could you explain our viewers what is the role of surgery in lung cancer?
Surgery is currently the only real form of curative therapy that we have for lung cancer, and is predominantly used in cancer when it is still early stage and localized just in the lung, or may have spread to the lymph nodes in the center part of the chest, and surgery may be used in combination with chemotherapy or radiation. But surgery still offers the only ability for us to be able to remove the tumor outside the body, as well as to sample and check the lymph nodes to make sure that the cancer hasn't spread to the lymph nodes at the time of surgery.
Also, can you tell us about the minimally invasive surgery and the robotic surgery and the difference between those two?
No, also, that's a great question about minimally invasive surgery. So, minimally invasive surgery for lung cancer has been around for more than 20 years. The traditional form is called video assisted thoracoscopic surgery, and surgeons will use 3 to 4 small incisions and ports and a camera to make incisions on either side of the chest to remove the lung. Robotic surgery is a variation of this that has been around now for more than 10 years and is growing increasingly popular. There may be some subtle advantages with using robotic surgery, but the full advantages are still being evaluated. The main thing, I think, is that at this point, especially in the developed world, that minimally invasive surgery, whether robotics or non-robotics, really should be the standard of care for early stage lung cancer.
So, what is the cure rate with the surgery, whether robotic or minimally invasive? What is the cure rate we are talking about with surgery in lung cancer?
So the cure rate after surgery really depends ultimately on the staging and also the treatments in addition to that. Historically, for early stage lung cancer, meaning lung cancer that's very small and located just in the lung and has not spread to the lymph nodes, the cure rate was as low, or the 5 year survival rate rather, was only about 70%. But that's also because in the early studies, many people also had bad emphysema, bad heart disease, and other comorbidities that decrease that survival rate. The newer data suggests that with early stage cancer, we're seeing 80 to 85% 5 year survival rates after surgery. So that's still not as good as other cancers, but we're improving with lung cancer all the time.
So, what are the factors you consider for a patient to be a surgical candidate? What do you look at when somebody comes to your surgery, and how do you determine whether they can withstand the surgery or not?
That's an excellent question. Thank you. The factors we look at to determine if someone's a surgical candidate really depend on their physical function and their pulmonary function or their lung function. So everybody who's getting lung surgery should have what we call pulmonary function tests, where you're breathing into a machine and they're evaluating how well your lungs are working. So that is one factor. And then also what your overall health is, how far you're able to walk, making sure that you don't have overriding heart disease or other major things that could cause you to have complications during surgery or after surgery. So if someone has good lung function and someone is able to walk and has good physical function, they should be able to tolerate most types of lung surgery.
Thank you so much, Dr. Reddy, for your time to educate us about the surgery, the role of surgery in lung cancer. Thank you. Radiation is one of the components of the treatment of lung cancer as well. And we have Dr. Dattatreya Nori, who is a very well-known radiation oncologist. He's the chair and professor of radiation oncology at New York Presbyterian and Cornell University, and is the recipient of Padma Shri Award for his contributions in oncology. Dr. Nori, please tell us what is radiation, what is the role of radiation in lung cancer, and what are some of the advances in the field of radiation oncology?
Radiation therapy for lung cancer uses high energy beam called X-rays to destroy cancer cells by damaging their DNA. It is very effective at controlling and eliminating the cancer cells. There are many significant technological innovations that occurred in the past decade to deliver the radiation with exquisite precision. Stereotactic radiation is one such pinpoint precision radiation delivery system. It is highly successful in treating small lung cancer lesions with excellent long-term outcome in excess of 90% local control. We started using this stereotactic radiation in the beginning, many years ago, in inoperable cancers, lung cancers, early lung cancers, as Dr. Reddy pointed out, inoperable. The results were so great, so good in inoperable, we moved the concept to treating operable lung cancers also. So even in operable, the outcomes are really outstanding. What is that? This technique is so important, so beneficial to why that? It is because the treatment is very precise. The large doses of radiation are delivered in a short period of fractions, 1 to 4 in a week, compared to 5 to 6 weeks of radiation treatments, a long protracted. So one advantage for patients is a short 1 week treatment in 1 to 4 fractions. And this is highly, extremely accepted by the patients because of the outpatient nature, short duration of treatment, and toxicity is less. In terms of biology, this stereotactic radiotherapy is superior to conventional radiation when we combine with the latest immunomodulation drugs. This is something is also very important. It works better than conventional radiation in combination with systemic immunotherapy. The other advanced radiation modalities are intensity modulated radiotherapy. This is self explanatory. Intensity modulation means we are intensifying the radiation dose to the center of the tumor and minimizing the radiation to the other areas. So, intensity is modulated. It significantly reduces the toxicities from the treatment. We use this technique for locally advanced lung cancers when combined with chemotherapy and immunotherapy. The other modality we commonly use is called four-dimensional planning and delivery system. What is four-dimensional? We know the three dimensions for any object. The fourth dimension is the motion, movement. So when cancers in the lung are moving with the lung, we use this technique, what we call respiratory gating, to synchronize with the breathing cycle for tumors that move within the lung. So this is also extremely useful technique for radiation oncologists. The last but not the least is the proton beam radiation therapy for tumors that are adjacent to critical structures such as spinal cord, heart, esophagus, in the chest. The standard radiation treatment deposits most of its energy through and through the tumor and also to the adjacent normal structures. Whereas this proton beam therapy deposits the entire energy of radiation only within the tumor.
Chemotherapy, immunotherapy, and target therapy have actually changed the landscape of lung cancer treatment. And we have a medical oncologist with us, Dr. Vandana Agarwal, who is a board certified medical oncologist and hematologist. And she's the co-chair of AAPI observership program. Dr. Vandana, could you explain us what is chemotherapy, what is immunotherapy, and what is targeted therapy, and how are they given, and what are the differences in their success rate, and what are the side effects?
Chemotherapy are medications which are given to cancer patients to treat cancer. Either they can be given alone or in combination. Immunotherapy is a recent advance in lung cancer management, and these are checkpoint inhibitors. They increase the immune system of patients to fight cancer on their own by increasing the immunity. Targeted therapy is for patients who express certain targets, and there are currently 8 of them. For some we have treatment and some we don't, and these targeted therapy helps target the cancer target without affecting the normal healthy cells. You may get some elevation in your liver enzymes or nausea or some effect on the lung called as interstitial pneumonitis. As far as immunotherapy is concerned, it is extremely well tolerated, but it has side effects which we monitor, which include diarrhea, some effect on the lung which may cause shortness of breath, fatigue, and some effect on thyroid as well as the pituitary gland. Side effects of chemotherapy are several and they are all manageable. Depending on the medications we use, they can cause hair loss, nausea, vomiting, effect on the blood count, maybe some tingling, numbness in hands and feet, maybe some sores in the mouth or diarrhea. And if the blood count, when it goes down, they are more prone to infections, fatigue. Those are the common side effects.
So, what is the success rate of these treatments? Could you enlighten us?
The success rate with immunotherapy is the highest, and patients are living longer and longer with good quality of life. 1 out of 5 patients can survive 5 years without disease.
Thank you so much for watching this show. And definitely there is a lot of advancement in the treatment of lung cancer in the form of surgery, radiation, and chemotherapy, immunotherapy, and targeted therapy, as our speakers alluded. And definitely the 5-year survival rate has gone up significantly. And special thanks to Dr. Vinod Sinha, the chair of AAPI Community Outreach Program, and the president of AAPI, Dr. Sudhakar Janalagadda. Thank you so much.